Well, good morning. Assalamu alaikum. First of all, thank you very much for the kind invitation to be part of this distinguished panel this morning. And congratulations for a really nice and well-prepared inauguration conference for this young society. And really congratulations for choosing to become a multidisciplinary team as opposed to focusing on one specialty, as is the typical situation in many of the professional societies. So this morning I'd like to very briefly talk about value in spine care, not from a clinical perspective per se, but more on the health services and health services research perspective, and a bit of the practical implications and applications of the definition of value when it comes to organizing health systems and organizing healthcare. Obviously, spine disorders are a cause of significant disease burden across the world. Musculoskeletal diseases contribute significantly to burden of disease and result in significant number of years of loss of disabilities. And back pain is one of the major causes of disability. Obviously, the cost for this is in the billions. These are the numbers from the U.S. And the case is similar in Saudi. This is a burden of disease study in Saudi, 2015, published. You see the musculoskeletal diseases are amongst the major causes of burden of disease in Saudi, following closely mental health and diabetes and and trauma. So if you look at it from the demand side, as economists would say, we have significant issue. You have chosen a field with significant demand. It's a significant problem, significant burden on individuals, families, and systems. If you look at it from the supply side, there's also a challenge of identifying what to do to manage disease, especially spine disease. This is an example of an intervention for spinal stenosis. This is data from CMS, Medicare in the US. You see two main interventions, decompression surgery versus fusion, and you see the trends and the performance of these interventions. And obviously there's a downward trend in decompression and upward trend in fusion. The question is, why did that trend happen? Is this because of a clear clinical evidence that fusion is actually more effective in these cases? Or are there other issues surrounding that? It becomes even more complicated if you look at variations in the use of each one of these two interventions. This is again data from CMS, Medicare in the US, through the Dartmouth Atlas of clinical variations. You see that between different hospital referral regions in the US, you have up to 10 times difference in the rate of performance of spinal decompression, and almost the same level of variation in the use of spinal fusion. So there's significant clinical variation in the use of treatment approaches to particular spine diseases. And it's not specific to spine, it's across the board. The difficulty is for us to, as clinicians and also as health system professionals or practitioners and policymakers and funders and payers, to select and choose and decide which one is worth the resources we're spending on. And there's where the concept of value plays an important role. One of the sort of reasons for variation is people have different outcomes that they're measuring. The standardization of outcomes is very important. and focusing on outcomes that matter to patients is extremely important. On the other hand, also focusing on standardization of the way we compute and calculate and estimate costs is also critical. And the unit that we use to computing costs is also very important. So if we come to a clearer understanding of this definition of value, we think it leads to a more focused approach to choosing the right clinical interventions. And for us to be able to do that, again, we need to start standardizing these two components. On the outcome side, there's an international effort today through the ICHM, International Consortium for Health Outcome Measures, to come up with outcome measures that are standardized nationally and even internationally. They have so far come up with multiple measurement sets for multiple conditions. One of them is low back pain. The measurement sets include a variety of measures. Some were discussed this morning by Dr. Hannah. And they focus on again, the outcomes that really matter to patients. We're talking about disability, work status, pain, quality of life, and also the clinical indicators like complications. And also at the same time, so you have standardization of the instruments or the measures themselves, but also you need to standardize the timing and sequencing of how you measure these things. So you use a baseline assessment, and then you do the subsequent evaluations in a very specific way, so you can compare results across different practices and even across different countries. The other way of looking at outcomes, which was mentioned by Dr. Sahel, is using registries. And registries have become a valuable and significant component in improving quality of care across the world. There are lots of examples in spine and other diseases in the States and Europe and elsewhere. And they are a very valuable source of looking at and measuring outcomes. When it comes to costs, identifying costs is one of the most difficult things in healthcare. And healthcare as an industry has really lagged behind compared to other industries and realizing and understanding the types of costs and types of resources utilized for specific diseases. In many cases, we have average costs, or even worse, average prices for an entire department or entire unit. And it's really rare that providers understand their costs at the patient level or at the condition level. So the direction in the world now is to start thinking of costs at the patient level using activity-based costing, and to do that not just for a particular incident, a particular encounter, but to do it across the pathway of disease. So you think about a spine condition, you have to think about the pre-surgical, surgical, and post-surgical periods, and how do you count the cost of the entire episode using activity-based costing. So how do we put these things together in a practical way? Probably most of us heard of value-based healthcare as a terminology. This is becoming a global trend and a global movement that tries to take these concepts of value, this concept of value, which is looking at outcomes and at the same time looking at costs, but doing this at the right level, which is patient level, and doing it at the right scope, which is the entire clinical pathway, taking that concept to implementation in practice. And this was pioneered by Professor Porter and Kaplan in Harvard. It started almost more than 10 years ago as an initial idea, and it started to spread across the globe now. And many of the principles here will be familiar to you, especially in this society in which you value multidisciplinary approaches and integration of care, because the whole thing actually starts with that. We need to develop multidisciplinary teams that look at the patient from all aspects, not just from a particular single discipline. Care has to be coordinated, has to be patient-centric, and people delivering that care have to be working together in a collaborative manner. So this is the number one principle, to be able to introduce value in our practice. Second is measurement of outcomes and measurement of costs for each and every patient. And for this is not an easy enterprise. It needs significant effort and infrastructure to be established. It needs a paradigm shift and a mindset change for clinicians and administrators. But it's quite valuable because this is really where we can identify wastes and identify inefficiency and identify ineffectiveness, and we can generate enough innovation in the system to continuously improve care. Then how do you link this to the system overall? How do you give the right incentives for people to do this and to do the right care and to continuously improve and look for higher quality and low cost? We have to give them the right, to pay them the right way, and this is what's called bundle payments for care, in which the providers are paid for the entire episode of care, not just for an office visit or an operation or a single admission, but for the entire episode of care. Let's say for a disc herniation, you start with the pre-op visits and all the management that takes place before that, all the way until rehabilitation after any intervention or any surgery, until even sometimes a period of 6 months or 1 year after that to make sure that recovery doesn't take place. Relapse doesn't happen. And then obviously this is at the individual institutional level. Then you can expand this across a whole system of delivery and across different geographic areas, and all of this will need to be supported by and enabled by information technology platforms. As we mentioned, this is a growing trend. It's in fact a well-established movement today. There are international public and private entities that are adopting this way of organizing care and also paying for care in the US and in Europe and Sweden. For instance, there are now bundle payments for spine surgery. In the US, the same. This is an example of a spine a bundle payment approach for spine conditions in Stockholm County in Sweden. And obviously, there are lots of examples there. So going now to the last question Dr. Khalid raised, in the healthcare transformation in Saudi, we are really focusing on emphasizing value in both the organization of healthcare providers as well as in the way care is being paid for. Dr. Spay mentioned the model of care that was launched by His Excellency the Minister of Health earlier this year, and the guiding principle of that model of care is care coordination, care integration, multidisciplinary approach to delivery of care, and the way we're looking at reorganizing Ministry of Health entities and hospitals and clinics is to support that model of care, to make sure that multidisciplinary teams are actually working together. We have integration of care across the different tiers of primary, secondary, and tertiary, and we have care coming to patients as opposed to patients coming to care. I think I'm taking more than my time. We can probably continue the conversation during the questions and answers. Thank you very much.